Tate Chronicles now transmitting.
Welcome to the Tate Chronicles on Healthcare Now Radio. And now, here's your host, Jim Tate.
Good day, citizens of the free world, from border to border, coast to coast, and to all the ships at sea. I bring you a warm welcome. This is your correspondent, Jim Tate, and thank you for tuning into the Tate Chronicles. Join me as we cut through the fog that exists at the leading edge of healthcare technology. My guest today is Brenda Hopkins. Brenda is the Chief Health Information Officer and General Manager for the healthcare practice at Consensus Cloud Solutions. Consensus offers a suite of solutions that solve some of the most significant challenges to interoperability. Brenda, welcome to the Tate Chronicles.
Thank you, Jim. It's great to be here with you.
I'm going to go back in history just a little bit, Brenda. Back to 2016. That's when the 21st Century Cures Act was signed into law by then-President Obama. Sounds like a long time ago. It was a long time ago. And a significant portion of that legislation dealt with the exchange of health information, and it really outlined a robust role for the Office of the National Coordinator to be involved in the regulation and development of health IT standards. Outlined in that was a process in which ONC would assist public and private partnerships to create, quote, a trusted exchange framework, including common agreement among health information networks nationally. That's a mouthful. But that trust exchange framework and common agreement is now known as TEFCA. And it was published last month, January 18th, 2022. And so my first question to you, Brenda, is how does interoperability fit into that 21st Century Cures Act, and how it might be impactful on healthcare delivery and payer organizations?
Right. So thanks for that question, and in listening to even how that's being described, it's quite challenging in complexity and ambition. But your question about how interoperability fits is as part of the 21st Century Cures Act, the interoperability rule really is trying to drive toward patient access to their own personal data, and it supports the ability to share that data. So consumerism and patient empowerment is central in the 21st Century Cures Act. It also bolsters a trend toward a patient-focused model, which it empowers both you and I as patients and our families to participate more effectively in medical care and hopefully improve public health services with that engagement at the patient, or if you want to say the consumer level. And then for payers, we're starting to pull together more deeply about gathering that data that resides in the payer space with costs and coverage and clinical interactions and data points. And all of these efforts aim to prevent essentially information blocking and improve the flow of easy patient access and the transfer of that data. So if you think back or have been in health IT a while, back in 2003, there was an implementation of HIPAA's version of what we're moving toward in information blocking. It was called the 4010 Electronic Transaction Standards Guidance. Again, standard, trying to get level set in the way we share information. And then more broadly across healthcare, the first stage of meaningful use has also encouraged the sharing of electronic health information, but it was more focused in the provider space. However, as the deadlines for the 21st Century Cures Act are starting to be reached, most payer organizations are not really prepared. There had been more preparation on the provider side. There's been a longer time to sort through the meanings and complexities and interpretations, but the payers are still coming up to speed, especially with the distraction in the last couple of years. If we don't mention COVID and we're in healthcare, we're remiss. So there's a lot of complexity, there's a lack of clarity, there's a lot of interpretation. And so these questions have created inevitable delays in reaching compliance with the new rule. And additionally, there's challenges existing around adhering to the Fast Healthcare Interoperability Resources standards, which here is FHIR, and conforming to the new public reporting mandates. And of course, developing the root capacity to ingest and communicate all that patient information and other from multiple data sources, and all by, as we all know, maintaining privacy and data security. These are large, complex things when you're working in an organization and trying to maintain operational efficiency and have this adjacent demand happening. So just to kind of pull that together, is we access and transfer our protected health information, our PHI, becomes common. It'll also increase the need to ensure our authentication and security measures around that as well. So all these new functions will be something that we who participate either in the provider or payer space need to be mindful in third-party relationships or partnerships, or places where we might not be able to leverage in our existing organizations.
You know, one thing I'm always interested about, Brenda, in terms of interoperability, is what some of the major challenges might be. Now, I remember back when the Meaningful Use program was birthed, the federal government really gave quite a bit of money to, whether it's individual providers or large practices or hospital systems, all kind of providers, essentially quite a bit of money to buy their EHRs. And so we really saw the widespread adoption of electronic health records. In terms of interoperability, I don't think we see so far any real stimulation or support in that kind of manner. So when there's no stimulation, it almost seems like a lot of providers go with the status quo. And so is that one of the top challenges, is that there is no mandate where they have to, or they're going to be penalized? And what are some of the other challenges you see for interoperability?
I think that's a good point, Jim, because when you think back to meaningful use, it was you had to do certain things, right, with the technology in order to receive payment in the provider area, we'll call it. But that type of use, or the incentives, the criteria weren't necessarily aligned with sharing data, if you will. It was to show utilization and adoption of the technology. So the incentives for data sharing didn't start from the beginning. It was more utilize, again, varied EHRs and varied code developments and different standards that were built in a certain way. So we did, I guess, if you want to highlight that, meaningful use did get health IT out front in the way of adoption. That did hit that mark. Did it hit the mark of being used purposefully in clinical workflow or payer workflow? That certainly on the provider side, there's a lot of dissatisfaction with that piece. That was a miss, as well as sharing data between different health systems or provider and payer organizations. So some of the challenges, again, are the inconsistent information that happen across multiple sources, particularly with different vendors I mentioned, with the different codes, the different nomenclature, if you will, and the way things are built. It's inconsistent. And so we've imposed that on our providers, who are at the first line taking care of patients, to figure out how to make sense of that. And it's really caused a lot of wasteless hours trying to figure out and how to make sense of what essentially the EHR is set up to be a billing system from the beginning.
Yeah, that's true. Just interrupt you there for a second. It was set up to be a billing system, and interestingly enough, I guess, the reimbursers have as much clinical information as the providers do, because they're not going to pay unless they are given that clinical information.
Yeah.
So
that's
they've got to be
absolutely-
part of the mix of interoperability, it seems like.
Absolutely. Absolutely. And so maybe the opportunity in that is that, as we sit here easily stating opportunities, right, is that it's not novel to say we need a single unified network or a single platform or, a uniform network to lay across data sharing, to automate the pulling of the data from the silos. But that could, if it was adopted, say you have a platform. Therefore, you're not built. We've already passed the mark where we're going to start from the same place and agree to build in the same way. But maybe there's this normalization, if you will, in the way of a piece of middleware that is uniformly used as a potential. Not sure if that's it, but it takes away that we, especially with the continued explosion of digital, we're going to continue to see more and more differences in the way we bring data in. Okay. So and I work in the TEFCA framework. I support the standards body. I understand where we're trying to drive toward, but I'm equally participating and understanding the amount of funding going into the digital area and the explosion of healthcare apps and devices that are going to capture data in ways that will never match, right?
Right.
The TEFCA framework. So therefore, as a suggestion, should there be opportunity in this normalization platform, or we can create a word, if you will.
Please.
Is that the place where we can make a little bit more sense?
Yeah, that's true. Well, the health information technology and that clinical data, obviously, one of the main benefits of it is healthcare delivered to the individual, but also health IT can bring a lot of support to the challenge of healthcare equity and the social determinants of health. We hear the last few years a lot more about that. So what are your thoughts about that, how health IT can support equity and social determinants of health? It's kind of a public health issue.
It is. You're right, Jim. It's a public health issue. It's a underserved ethnic minority population issue that we need to be purposeful in addressing. So health IT has the opportunity in the tools we use. We have phones, we use computers. I want to start there, and that the tools are sort of there. Mm-hmm. And the way we embed, if you will, the ways and the content into those are the opportunity to reach these underserved minority populations. So things that might look like patient support pieces for reminders and self-care programs to, engage. You can also increase the availability of accessibility for COVID-19 testing and vaccination for these people in the way of education that are being so disproportionately affected right now. There's also screening tools that the government has, like the health-related social needs screening tool. That's a standard screening tool developed by CMS and the Innovation Center to determine if systemically screening for, say, a health-related social need has an effect on total healthcare costs. There's point-of-care assessments. There's holistic care plan generation, population-level reporting, health equity tools that help in assisting communities socially, culturally, physically, in order to improve the health and safety elements. Those things around social and racial justice all can help, be mobilized again with tools that we use today. Our phones are extremely popular, especially, with our younger, but all really. Sure. The importance of all the apps when you look on your phone today, right? Now we're in COVID and you had to get an app about participating in different places to get across borders and conferences. Think about if we were to enable all the smart content clinically in the way to how to engage these underserved populations. And if there's anything probably they can't afford, it's going to be internet and a phone. Can we explode and reach people in a way that already serves them in many other platforms in banking and shopping and so forth?
Mm-hmm. For our listeners who may have just joined us, this is Jim Tate of the Tate Chronicles. I'm speaking today with my guest, Brenda Hopkins. Brenda is the Chief Health Information Officer and General Manager of Healthcare Practice at Cloud Consensus Solutions. Consensus offers a suite of solutions that solve some of the more significant challenges to interoperability. Brenda, so at Consensus Cloud Solution, who are your customers, and do you provide technology or workflow processes? What do you do for your customers?
Oh, that's a good question. We do a lot of both of those things. Mm-hmm. We do provide some products. Some of those products are back to the original statement of faxing. We've modernized into the cloud, if you will. So that's really fundamental interoperability. I'll just give you a small example because I'm a nurse, and 1 weekend a month I get on a plane and I work in at least 3 to 5 different systems. And I use that technology because I start in one system, I get on a plane, I log into another system, and I land and have to report in another. And that technology still has a very important part in that transport mechanism, as well as not everybody can afford to hire people to the level of standards and work that's, in the populations they're serving in healthcare. So we have digital cloud faxing modernized into the cloud. So there's API integration into EHRs. We also have professional services that optimize workflows for our other products that include using signature products, include OCR, NLP, and AI to track metadata, if you will, on top of a document in the way of a static image. Now you can put that in a data mart or an EDW. We also have what we talked about a little bit before is platforms that help in looking for ways to normalize data, but also make connections to the bigger networks in TEFCA and what was carry quality. So I think we're trying to be at service for wherever you are in your digital journey. From if you still choose to use a fax transmission, we can liberate that into the cloud for you, as well as we can take you forward into artificial intelligence and the use of metadata and data marts and EDWs, as well as platforms, and also bring our professional services, managed service, and engineers to help you workflow that in an optimal way.
One of the things, Brenda, that, they say every cloud, no pun intended, has a silver lining. And the global COVID pandemic that hopefully we're nearing the end of really showed us some gigantic gaps in the ability to do real-time reporting of data. And so whether that was folks who were receiving immunizations for COVID, or who were tested positive or negative, many different regions, many different states reported this information in many different ways, and didn't collect necessarily a lot of information as to who was even receiving immunizations. And so as that data was collated and went up the chain to where public policy was being made, those folks, in one sense, really were flying blind. So we really identified some terrible gaps. So to me, that may be the silver lining, is that we know those gaps are there. How can those gaps be closed for the next public health emergency? And so how do you think health IT can help organizations prepare and maybe manage differently based upon what was hopefully learned during the COVID-19 pandemic?
I agree with you. We must learn, hopefully, and must learn, right, to do different. And I think that's where it starts, is, as you're pointing out, and I agree, the data, it's hard to have leadership positions when you're depending on data and have that data to be questionable. So we need to kind of take a step back and look at a very basic level, how we're capturing that. And the behavior, quite honestly, of the people that are being asked to do that, right? Garbage in, garbage out, as they say, to help them be educated and understand the importance of the why, so that they're empowered with tools to capture it in a way that's elegant in their workflow and not distracting, is a good start in the way of building technology, right? For the overall goal of enablement of improved outcome. So I would say at a very basic level, it's the design and configuration of how and what we're asking the people to capture to get the best outcome, that we have more confidence then in the utilization and reporting as a start. And then for us not to know, I mean, we all hope we're moving into a time when COVID's not going to be a part of our life as it's been, but we can't forget the how to work virtually. We can't, envision our organizations not having some planning forward that includes VPNs and computers and phones, telehealth in the case of healthcare, and virtual engagement and education to be a part of our portfolio moving forward. To think that this wouldn't happen again, in my opinion, seems not the best approach. But we also miss the people element, and we want to bring that back together. So I think the opportunity for health IT is really in the planning and preparation for what most likely, unfortunately, will be another event in our future. And if we can minimize that with the approach of the way we manage the way we do public health and public reporting and putting more thought into that, logistics for PPE, testing, tracking, reporting, remote work, and remote monitoring, I think that's only going to help us, even in our engagement on a more global level to attack this pandemic. We have to think virtually. We have to think that way to engage our participants on a global level.
Just the concept of registries, immunization, vaccination registries, that there is not one registry there. Every state has one. Some large cities have their own. So the ability to collate that data, which is so filled with static, and really not enough demographic information to really identify things, is problematic. And so we'll see how the policies change and what gets developed around that. There's got to be some different workflow. We've got the technology, but the way the data is handled, we saw. They say you don't want to see how laws are made or sausage is made. Well, we saw it. We saw how it was made with that data reporting. Something else I'm always interested in is asking folks, and I'd like to ask you, where you think we are in the trajectory of interoperability. I was on a roundtable yesterday and I asked that question, and someone said, well, they had seen the conception and the gestation and the birth of the baby, and the baby has been fitted with baby shoes, but the baby wasn't walking yet, which I thought was a pretty good analogy. Where are we in the trajectory of interoperability?
Well, that's an interesting question for me because of that word interoperability and how people define that. If interoperability means a complete open and sharing of information anytime, anywhere in healthcare at any time, we may never get there. Okay, because is it technically possible? Sure. But there's politics and there's people and there's agendas that may, if we were all to be very honest and take a step back, may really not be in line with this stated goal of true interoperability. And the ability to influence those agendas and the disparity may never be hit. Now, I don't want to end on a negative note, but I want to be a realistic person as well, because I do work in this space and work in large groups and understand there's many agendas. But that said, we should all sort of put we must put the patient at the center, and whatever that patient needs to remain whole and healthy, it's their data, and we need to respond in accordance. And if we only look at, that ability, given the differences in environments and what that might mean, maybe that becomes the place versus we're all going to work together equally and participate. I don't think that's possible due to resource allocation and different focus. So I remain hopeful and involved and supportive, and again, putting the patient family at the forefront of trying to get to that space will lead us to the right area in our true north.
Brenda, that's spoken as a true nurse, and as long as we keep moving forward, that's good. So if we can get the baby walking on 2 feet, let's do that first, and then we'll worry about walking fast or running. So one step at a time. And I want to remind our listeners, if they want more information about the solutions offered by Consensus, they can go to consensus.com. Not spelled weird at all, just Consensus, CONSUNSUS.com. Thanks for joining me on this episode of the Tate Chronicles. I offer a special salute to my guest today, Brenda Hopkins of Consensus Cloud Solutions. Brenda, thanks for coming aboard today.
My pleasure, Jim. Thank you.
You can find more information on this show's program page at healthcarenowradio.com. Until we meet again, here's wishing you smooth sailing and safe harbors.
Tate Chronicles transmission ending now.